Hi, my name is Emma Williams, and together with April Beaton, Julie Ty, Emma Hall, Min Lee Miggs, and Carolyn Leviston, I will be talking to you today about acquired dysphagia after stroke and our proposal for implementing clinical practice guideline recommendations in this area. So why, you might ask, is dysphagia such an important consideration after stroke? Well, firstly, whilst most people survive their first stroke, they often experience significant morbidity. Prevalence rates for dysphagia in the acute stages post-stroke are as high as 50%, and prevalence remains at approximately 10 to 28% 2 weeks after the occurrence of stroke. The prevalence of dysphagia after stroke is even more concerning when we consider the potential complications that may arise. So what are these complications? Well, some of the complications that may arise from dysphagia include aspiration pneumonia. So, if food or liquid passes the vocal folds and enters the lungs, aspiration pneumonia may develop. While some overt signs of aspiration may be present, for example, coughing and choking post-swallow, silent aspiration can also occur, hence aspiration may not become evident until symptoms of a chest infection become apparent. There is also malnutrition. If a patient is unable to swallow safely, he or she will often limit their food and liquid intake, which can lead to malnutrition and dehydration. If this occurs, tube feedings will often need to be temporarily instated in place of oral feeding. Both aspiration pneumonia and malnutrition have the potential to prolong a patient's hospital stay, a situation which is frustrating for the patient and family and also increases demands on an already strained healthcare system. Evidently, the role of the speech pathologist as an agent of swallowing intervention, management and rehabilitation is extremely important. But what can a speech pathologist do to help? The speech pathologist will first evaluate the nature of the patient's swallowing problem. This usually involves an oral motor examination to determine whether or not there is any cranial nerve damage that may be affecting the patient's ability to swallow. Next, a bedside swallow examination is performed, with trials of foods and fluids of varying textures and consistencies. During these trials, the clinician will look out for any overt signs of penetration of food and fluid past the vocal folds. If the clinician is unable to gather information from these examinations, instrumental examinations may be performed, and these include video fluoroscopic swallowing study, which allows the clinician to obtain a video image of the upper aerodigestive tract during the act of swallowing. The patient may be trialled on various foods and fluids of different textures and consistencies, which are mixed with a barium. There is also the fibre optic endoscopic evaluation of swallowing, and this involves the insertion of a flexible scope through the nasopharynx and into the hypopharynx, allowing real-time video of these areas during swallowing. However, the oral cavity and esophagus cannot be viewed with an endoscope, and the endoscopic image is lost at the peak of the swallow. These evaluations assist the speech pathologist to decide which forms of intervention will be most appropriate. Behavioural interventions for dysphagia may include food modification. So, these are the most widely used behavioural interventions for dysphagia therapy. Food and liquid may be modified in various ways to compensate for the swallowing deficit. For example, thickening fluids assists by slowing the swallowing process, thereby allowing greater time for coordination of the swallow. Modifying feeding activity, for example, coordinating the timing of meals and medications so that the patient is not drowsy during mealtime. Patient modifications. This can include positioning strategies. For example, the patient may be asked to do a chin tuck during swallowing to assist airway protection. Mechanism modifications. These include motor exercises, sensory stimulation and prosthetic adjustment to compensate for physiologic or anatomic deficits of the swallowing mechanism. Swallowing modifications. These modifications focus on changing the physiology of the swallow to increase safety. They require intensive practice by the patient so that they become automatic. So, whilst these are the widely used intervention, management and rehabilitation strategies, we wondered, what does the best evidence say, and where is the best place to find this evidence? Well, clinical practice guidelines are generally the best port of call as they synthesize all of the best available research evidence, including systematic reviews, and provide recommendations based on this synthesis. As part of our project, we sought out to find out some of the most relevant clinical practice guidelines for acquired dysphagia after stroke. I will now pass over to April, who will talk to you a little bit more about the search strategy.